Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in today's module, we are going to discuss about the Mullerian malformation. So as we have discussed in the previous module about the Mullerian duct and the development of the female internal genital organ, in this module, we'll be discussing about the malformations. So these malformations could either be because of the problem in the formation of the Mullerian duct, or it could be in the problem with the fusion or the problem with the resolve of the septa. So these could be about the Mullerian malformation. So now let's start with the Mullerian malformation. So they've ideally classified this Mullerian malformation into classes. So there is going to be class 1 to class 7 of Mullerian malformation. The first class is all about Mullerian agenesis. So Mullerian agenesis belongs to class 1 of Mullerian malformation. So in Mullerian agenesis means absence. So here the two Mullerian duct, we all know that in every single female patient there is going to be two Mullerian duct, one on each side. One is going to be on the right side and one is going to be on the left side. Right? So each side it will give rise to half side of uterus, half vagina, upper part of the vagina, half cervix and one side fallopian tube. Is that clear? One Mullerian duct will give rise to one side fallopian tube, one side half of the uterus, one side half of the cervix, one side half of the upper part of the vagina. The lower part of the vagina is going to be derived from the sinovaginal bulb of the urogenital sinus. Ovary is going to be developed from the genital ridge. But in class 1 of Mullerian malformation, the problem is that there is Mullerian agenesis, that is, there is going to be absence of two Mullerian duct. Both the Mullerian duct are absent in this patient. Since both the Mullerian duct are absent in this patient, therefore, there is going to be no female internal genitalia. No fallopian tube, no uterus, no cervix and no vagina. But the ovary is going to be present because ovary is actually developed from the genital ridge. Okay. Mullerian agenesis is the most common Mullerian malformation which is associated with the renal anomalies and skeletal anomalies. So since it is associated with renal and skeletal anomalies, it is also termed as Murg's association, MURCS association. So Mullerian agenesis is also termed as Mayer-Rokitansky-Kuster-Hauser syndrome. Mayer-Rokitansky-Kuster-Hauser syndrome. Is that clear? Okay, so in this patient, the ovary is going to be normal. So because of that reason, they can have their own biological child, but with the option of IVF and surrogacy. Since they don't have any uterus, cervix, vagina or fallopian tube, they have to adopt IVF plus surrogacy. Is it clear? Okay. Now let's discuss about the class 2 of the Mullerian malformation. So class 2 is all about unicornate uterus. So uni of unicornate uterus stands for single. Uni means single. So here the problem is that only single Mullerian duct is present. So as we all know, one Mullerian duct will give rise to one side fallopian tube, half of the uterus of that side, half of the cervix of that side, half of the upper part of vagina of that side. So since only one side of the female internal genital organ is going to be present, it's going to look like a banana. So because of that reason, it is going to be called as banana-shaped uterus. And this unicornate uterus is the second most common Mullerian malformation to be associated with the renal anomalies. Is that clear? Okay. Now let's discuss about the class 3. Class 1 was about Mullerian agenesis. Class 2 was about unicornate uterus. Now class 3 is about uterus didelphys, where di of didelphys stands for 2. So here, two Mullerian duct is present. But the problem is that we all know that by around 10 weeks, these Mullerian duct has to fuse. Because of failure to fuse, there is going to be two separate fallopian tube, two separate uterine cavity, two separate cervix, two separate upper part of vagina. Is that clear? In unicornate uterus, only one Mullerian duct was present. So one Mullerian duct gave rise to one side fallopian tube, uterus, cervix and upper vagina. But in didelphys, two Mullerian duct are present. So two Mullerian duct will give rise to each side fallopian tube, each side half uterus, each side half cervix, each side half upper part of the vagina. But as we know, by 10 weeks these have to fuse. The right and left Mullerian duct have to fuse and result in the formation of the septa. But here there is failure to fusion and failure to formation of the septa. So since they fail to fuse and result in the formation of the septa, there is going to be two fallopian tube, two uterus, two cervix and two vagina because of absence of fusion. So since two vagina is present in this patient, if you are going to do an investigation called as hysterosalpingogram in order to test the tubal patency. In this test, you have to introduce an instrument called as Leach-Wilkinson cannula. Through this cannula, you have to introduce an iodinated dye. So this dye will pass through the tube, and if there is going to be any abnormality in the patency of the tube, it is going to be looking like a filling defect. Is that clear? But in patients with uterine diadelphys, 2 vagina is going to be present, and 2 uterus is going to be present, and 2 fallopian tube is going to be present, and 2 cervix is going to be present. So ideally, you need to introduce 2 separate Leach-Wilkinson cannula, and you have to give the dye to 2 separate Leach-Wilkinson cannula, which is inserted in 2 separate vagina. So the only uterine malformation which is associated with 2 vagina is going to be uterine diadelphys, and the problem here is that failure to fusion of the Mullerian duct. And this uterine diadelphys has the second best reproductive outcome. Okay, since the uterine cavity is going to be separate, 2 separate uterine cavity is going to be present, therefore they have the second best reproductive outcome. So basically, the patients who are born with Mullerian malformations, they are going to have some obstetric complications such as recurrent pregnancy loss, which means 3 consecutive pregnancy loss or infertility because of this abnormality in the development of the female internal genital organ. So of these 7 classes of Mullerian malformation, the second best reproductive outcome is going to be from the uterine diadelphys, and this is based on the fact that 2 separate uterine cavity is present. Is that clear? Okay. So in uterine diadelphys, the problem is with the fusion. So since the problem is with the fusion of the 2 Mullerian duct, the treatment is going to be fusion. You have to do unification surgery, where you're going to convert this 2 separate Mullerian duct into a single uterine cavity. You have to convert this 2 fallopian tube, 2 uterine cavity, 2 cervix, and 2 upper part of vagina into a single uterine cavity, which consists of 2 fallopian tube, 1 single uterine cavity, 1 cervix, and 1 vagina. So the treatment of uterine diadelphys is unification surgery. Now let's discuss about the class 4 of the Mullerian malformation. Here I have missed one point, that is the malpresentation. So since 2 separate uterine cavity is present, there could be malpresentation as well. So what is malpresentation? So we all know that when the head of the fetus is going to be near the presenting part, that is the presenting part is the head of the fetus. Okay, so that has to lie near the internal os, the lowermost part of the uterus, that is going to be the... See, let me explain you through this diagram. See, so this is going to be the uterus. So in the uterus, how the baby is going to lie? The presenting part is going to be that part of the fetus which is going to be in the lowermost part of the uterus. That is going to be the presenting part. So here, as you can see here, this is the uterus and this is the lowermost part of the uterus, which is near the internal os. The head is going to be the presenting part. So when the head is going to be the presenting part, it is termed as cephalic or vertex presentation, and this is the most common presentation. So any presentation which is going to be apart from this cephalic or vertex presentation is going to be malpresentation. And what are those malpresentation? Breech and transverse lie. Breech means the head of the fetus is not going to be present in the lowermost part of the uterus. Instead, the foot of the fetus, the knee and the footling presentation, where the knee and the foot of the fetus is going to be present near the lowermost part of the uterus. That is going to be the breech presentation. So in breech we have knee, footling, right? So these are the breech presentation, where the knee or the foot is going to be present at the lowermost part of the uterus. In transverse lie, it is also a malpresentation, where the fetus is going to lie in a transverse position, where the head is going to be on one side and the leg is going to be on the other side. Is that clear? So in uterine diadelphys, the most common malpresentation is going to be the breech presentation. Since 2 separate uterine cavities present, breech could be the most common malpresentation in uterine diadelphys. So now we are going to discuss about the class 4. Class 1 was about Mullerian agenesis, class 2 was about uniconvate uterus, class 3 was about uterine diadelphys, class 4 is about biconvate uterus. In biconvate uterus, both Mullerian duct are present. And both Mullerian duct are present at around 10 weeks, the fusion has begun. The problem is that the fusion is going to be incomplete. The process of fusion has started but around 10 weeks, but the fusion is incomplete. So since the process of fusion has started, we all know that the fusion is going to be starting from below upwards direction. So which is the part which is going to be present at the lowermost part? Vagina is going to be the lowermost part. So since vagina is the lowermost part, as the process is going to begin, the vagina is going to be fused initially. So since the process is going to be initially, the vagina will fuse, but above the vagina, the cervix is going to be either fused or unfused depending upon the stage of incompletion. If the stage of incompletion is going to be at the level of cervix, it is going to be result in 2 cervix. So 2 cervix if present, it is called as bicollis. If one cervix is present, it is called as unicollis. So the vagina is going to be one as the process of fusion has begun, but if the process has not fused at the level of cervix, then it is going to result in bicollis. If it is going to fuse at the level of cervix, it is called as unicollis. But definitely the uterus is going to be two separate uterine horns is going to be present, and two fallopian tube is going to be present. So in bicornate uterus also, two uterus will be present and one vagina will be present, and depending upon the stage of fusion and incompletion, the cervix will be either 1 or 2. If it is 1, it is unicollis. If it is 2, it is bicollis. And what is the malpresentation which is common in bicornate uterus? Since there are two separate uterine cavity, it could be either a transverse lie or a breech presentation could be the malpresentation. Right? And this bicornate uterus is the second most common Mullerian malformation. So the most common Mullerian malformation is the class 5, that is going to be the septate uterus. The second most common Mullerian malformation is class 4, that is the bicornate uterus. So since the problem in the class 4 bicornate uterus is the failure of fusion, you have to do the process by yourself. So you have to start the fusion. You have to remove any abnormal tissue that has been present and you have to fuse. If the fusion has not occurred at the level of the cervix, you have to start the fusion at the level of the cervix and convert this into a single uterine cavity. So that is termed as Strassman metroplasty, where you're going to remove any abnormal tissue being present and you have to fuse and suture it. So once you suture it, it will convert into a single uterine cavity. Is that clear? Okay. Now let's discuss about the most common Mullerian malformation, and that is going to be the septate uterus. So this is the most common uterine malformation. So we all know that by 10 weeks, both the Mullerian duct is going to fuse and result in the formation of the septa. And this septa has to resolve by around 20 weeks. So only when the septa resolves by 20 weeks, it is going to result in the formation of a single uterine cavity. So, but in patients of septate uterus, the problem is that once the septa has formed by around 10 weeks, there is failure to resolve of the septa. So since the septa hasn't resolved, therefore the uterus is going to be two uterine horns. So only when the septa is going to resolve, the uterus will be converted into a single uterine cavity. So because of this failure to resolve of the septa, two uterine horns will be present, but single vagina and single cervix is going to be present. Is that clear? So because of the presence of this septa, which is going to actually make some problem with the developing fetus, it is going to result with the most common complaint of recurrent abortion. So because of the presence of septa in the uterine cavity, the most common complaint with which a patient with septate uterus is going to come is recurrent abortion. Recurrent abortion and infertility is the most common complaint in a patient with septate uterus. Is that clear? Okay. So if at all the pregnancy is going to continue, it is going to result in some malpresentation. What is malpresentation? Transverse lie is going to be the most common malpresentation. So because of the septate uterus, as you can see here, because of the presence of the septa, the fetus can be either in a transverse location. So transverse lie is the most common malpresentation in septate uterus. Is that clear? So what is the ideal treatment? Septa is the problem here. So please resect that septum. So through the hysteroscope, you are going to resect the septum, which is termed as hysteroscopic resection of the septum is the treatment of choice for septate uterus. Is that clear? Yes. So most common Mullerian malformation is septate uterus, followed by the bicornate uterus. The most common Mullerian malformation to be associated with recurrent abortion is also septate uterus. Now let's discuss about the class 6. Class 6 is termed as arcuate uterus. So in arcuate uterus, the best reproductive outcome is going to be from the arcuate uterus. So previously we discussed that the second best reproductive outcome is going to be from the uterine didelphys, where two separate uterus is going to be present. But the most best reproductive outcome is going to be from the arcuate uterus. So arcuate uterus has the best reproductive outcome, followed by didelphys. Is that clear? Yes. So arcuate uterus, the problem is that it has a dipped fundus. We all know that the last step of this Mullerian duct, which is giving rise to the female internal genital organ formation, is going to be the fundus of the uterus is going to become dome shaped. But here, the fundus of the uterus, there is going to be slightly dipped fundus. Dipped fundus is going to be present in patients with arcuate uterus. So the problem is only with the fundus, therefore it has the best reproductive outcome. Is that clear? Okay. What is class 7 of Mullerian malformation? So class 7 is nothing about in utero exposure to diethylstilbestrol. So diethylstilbestrol is actually a teratogenic agent. Okay, so if a female fetus is exposed to this diethylstilbestrol when in the mother's uterus, it has certain complications. So what are the complications? So if a female fetus is exposed to the diethylstilbestrol in the intrauterine period, to be even more specific, in the first trimester, it can develop the most common malformation, that is going to be the hypoplastic uterus. What is hypoplastic uterus? Underdeveloped uterus is hypoplastic uterus. That is the most common malformation in female fetus who are exposed to diethylstilbestrol in the intrauterine period. The most specific is going to be a T-shaped uterus. The uterus is going to be T-shaped. Is that clear? Okay. Not just that, even after the female fetus is going to be born, because of the exposure to diethylstilbestrol in the intrauterine period, there are increased chances of clear cell carcinoma of the vagina and the cervix. There are increased chances of malignancy in this patient, and it is going to be the clear cell carcinoma variant of the vagina and the cervix. So this is all about in utero exposure to diethylstilbestrol. So earlier it has been told that all female fetus who are born to mother and all female fetus who are exposed to diethylstilbestrol in the intrauterine period, renal anomalies are more common in them. But recently it has been stated that there are no chances of renal anomalies in fetus who are exposed to diethylstilbestrol in the intrauterine life. So now let's discuss about the investigations. So the most commonly these Mullerian malformations are an incidental finding. What are incidental finding? Let's say, for example, a female is going to come for some other complaint. Okay, she is going to come for some other complaint, and for some other complaint you are going to do an ultrasound of the pelvis. So while doing the ultrasound of the pelvis, a transvaginal sonogram or the hysterosalpingogram for testing of the tubal patency, only while doing that for some other purpose. Let's say, for example, a female is coming with complaints of infertility to me. So as a approach of infertility management, as an investigation, I'm going to order HSD to her. So while doing the hysterosalpingogram, as an incidental finding only, I'm going to diagnose this Mullerian malformation. So most commonly it is an incidental finding which is diagnosed on transvaginal sonography or the hysterosalpingogram. But what is the investigation of choice, and what is the gold standard investigation? So the investigation of choice is going to be 3D ultrasound. 3D ultrasonogram is the investigation of choice for Mullerian malformation, and the gold standard investigation for the diagnosis of Mullerian malformation is magnetic resonance imaging. MRI is the gold standard management. And the last resort could be the laparoscopy and the hysteroscopy. With the laparoscopy, you can actually visualize the fundus of the uterus. So while you visualize the fundus of the uterus, you can diagnose the arcuate uterus, and you can actually differentiate between the bicornate and the septate uterus. By how? Because we all know that between the class 4 and the class 5, you cannot differentiate based on the findings which we are visualizing on the HSD, right? So ideally you have to look at the fundus of the uterus. In bicornate uterus, how would be the fundus? And in septate uterus, how would be the fundus? See, in bicornate uterus, the fundus will be divided because two separate uterine cavities present, and since the fusion is incomplete, the fundus is going to be divided. So when the fundus is going to be divided into two, it is bicornate uterus. When the fundus is not going to be divided into two, it is septate uterus. The other difference is that the angle between the two uterine horns is going to be obtuse angle. That is, the distance between the two uterine horns will be more than 4 cm in bicornate uterus because of failure of fusion. But in septate uterus, the problem is not with the fusion. The problem is only with the septate, presence of the septum. So therefore, the fundus will not be divided, and the angle between the uterine horns is going to be the acute angle. That is, the distance between the uterine horns is going to be less than 4 cm. Is that clear? So the distance between the two uterine horns is going to be less than 4 cm, and the angle is going to be acute angle because the problem is only with the septum in septate uterus. But in bicornate uterus, the fundus of the uterus is actually going to be divided into two because of this failure of fusion. Since the fundus itself is going to be divided, therefore the distance between the two uterine horns is going to be more than equal to 4 cm, and the angle is going to be obtuse. Is that clear? Okay. So with laparoscopy and hysteroscopy, with hysteroscope you can actually visualize the interior of the uterus. But with laparoscopy, you can visualize the fundus of the uterus as well. So the last resort could be laparoscopy and hysteroscopy. So these are the basics about detailed explanation about the Mullerian malformations. Well, there are 7 classes of Mullerian malformation. Class 1 is Mullerian agenesis, Class 2 is unicornate uterus, Class 3 is uterine diadelphys, Class 4 is bicornate uterus, Class 5 is septate uterus, Class 6 is arcuate uterus, Class 7 is in utero exposure to diethyl stilbestrol. So we have discussed everything in detail about Mullerian malformation. You need not worry about this Mullerian agenesis because we will be discussing about Mullerian agenesis in a separate module as well. So I hope that I have made this topic very simple in a tabular column. In case if you have any doubt or if you want me to repeat this topic, you please write to us in the Mackler handle. Is that clear, students? Okay, so let's meet in another module. Thank you.